Okay, great. I'm so glad to be invited here today to share CRISP's work with health plans, especially our work with Maryland Medicaid and the Maryland Managed Care Organizations, the MCOs. In today's discussion, Angela and I will be addressing facilitating care management follow-up and interventions after telehealth visits. And in this discussion, we're going to highlight CRISP's work with MCOs and with building connections with providers and building this all on shared data. So I'm Mary Pohl. I'm a senior advisor to CRISP. I work with in a number of different areas in CRISP, including you'll probably see me in the rural health program that Christian described earlier today. But in this capacity, I work with Ruthie Kessel, and we provide strategy and support and outreach to providers and or to the, I'm sorry, to the payer community. We provide payer strategies and support for CRISP Maryland. And I've been working for a number of years with Angela Hart, and I'm so glad that she's joining me to go through this presentation. And Angela, will you introduce yourself real quick?
Sure. Thank you, Mary. Good morning. I'm Angela Hart, the Senior Director of Care Management for Maryland Physicians Care. I've been working with Mary, and she mentioned Ruthie for several years now, and really look forward to sharing my perspective on how better data sharing has changed the way we can support our members through care management.
Thanks so much, Angela. And Kevin, can you go on to the next slide for me? Thanks. Before Angela and I discuss our work, I wanted to just pause for a moment and talk a little bit more broadly about the work that CRISP does with the payer community. And while much of CRISP's work has focuses on health providers, health plans have been active as CRISP participants since our initiation. Along with providers, the tools, the services, the data have changed significantly across time. And and the and but now today they've changed across time, but now today CRISP users broadly, whether you're a payer user or a provider user, share the same data resources. They, to the most extent, share the same data sets. And this data supports a number of different payer permitted purposes. The payer permitted purposes I have fall into a couple of different areas. Work to improve quality of care, work to improve care management, and under care management, a lot of administrative efficiencies. So the last presentation on modernizing maternal care was one of the examples of where we worked with payers, we worked with providers, we worked with the Maryland Department of Health, MCOs, and local health departments to think about ways to improve that MPRA process. So that was administrative efficiency to support care management and care coordination. So going on to the next slide. So how does CRISP cultivate ideas for new services and tools with our payer communities? Well, starting about 6 years ago, we steadily increased our outreach and coordination with Maryland health plans, especially with our MCOs and Maryland Medicaid. Maryland Medicaid about 6 years ago started providing Medicaid claims data to CRISP, and we have a number of different resources that are built off of that claims data, including the availability of that claims data on a patient level in our portals. I also wanted to pause and just say, and MCOs have been tremendously great partners to work with. The MCOs provide a ton of care management work, and the care managers in MCOs are working closely with the most vulnerable populations in our state. The care managers working day in and day out with our patients. And so now we meet at least quarterly with each MCO, and most of the MCOs bring to the quarterly meetings folks like Angela and her team from care management. And these care managers who are working day in, day out with patients have a lot of ideas about how our tools and resources can support them and things that we should add to our system, reports that we should provide that will help their care managers with their work functions. So going on to the next slide. So it was in one of these quarterly meetings that Angela and her team brought up some ideas about the work that we're going to discuss today. So I'm going to turn it over to Angela to talk about the problem that they were facing and why they came to CRISP to help solve their problems.
Thanks, Mary. Yeah, so before we get into the details of how CRISP helped us solve our problem, I'll just give you a little bit of background about the need we identified. So we have a 24/7 telehealth vendor called My Virtual MPC. At a high level, this vendor serves several key functions. It provides our members with a touch point between office visits or while they're waiting to get into a new provider. It can provide after hours access so members are not defaulting to the emergency department. It can support timely follow up and adherence to discharge instructions after a hospital or emergency room discharge. And it also gives our highest need members an additional resource when they need it the most. So when these members use the platform, the telehealth provider documents all of their clinical findings, the assessments, their recommendations, and a standard visit note. It's a valuable service, but the problem was that documentation was staying siloed with the telehealth vendor. Having access to that visit note was incredibly valuable to us as care managers and the PCPs, and that disconnect is ultimately what brought us to CRISP. Next slide, please, Kevin. So the problem we kept hearing continually from providers and my internal team was we don't know what happened in these virtual visits. This wasn't just a minor inconvenience. It really meant that the PCPs and care managers had zero visibility into these telehealth encounters. The visit notes were not making it into the shared health record, which led to duplication of assessments. And in some cases, coordination gaps were causing delays in follow-up and referrals. We needed to solve the disconnection between the virtual visit and the rest of the patient's care team. That telehealth encounter could not continue to exist in a silo. It needed to become part of the full clinical picture. So our specific request to CRISP was to facilitate a connection between our telehealth provider and the CRISP portal so that our care management team and the patient's broader care team could coordinate after these virtual visits. It wasn't just about getting the data in the system, it was about enabling action on what was there. We wanted the care managers to know what happened in the visit before they picked up the phone, and we wanted the PCPs to see these notes when the members were in their office. And that's what brought us to CRISP. And I will next hand this back to Mary so she can explain how she made this happen.
Thanks. And on the next slide, Kevin. So CRISP solution. So Angela and her team brought this idea to CRISP. Hey, we need to get these notes into the system. And our providers have said, like, let's put them in CRISP. This would make a lot of sense to everyone. Instead of trying to like build a solo pipeline that was going from the vendor to MPC, let's get them out to everyone, including the clinical providers. And so in many ways, I was like, okay, great. This is like a pretty bread and butter crisp solution. Like this is a provider who is willing to provide their clinical notes and wants to integrate with CRISP. There were, of course, a couple of areas where we needed to work through with the provider. First, this was an out-of-state provider who was not at all connected to CRISP. They had not shared data with an HIE. And so we needed to sign the vendor up as a provider, the My Virtual MPC vendor up as a provider, and connect them into CRISP. Also, the vendor was not able to produce a standard HL7 file, and in our world of data connectivity, we like to work in standards. It's the best way we work, and in most providers have electronic health records where their systems are able to produce data in standards, but this was not the case for this provider. So going on to the next slide, I'll talk a little bit more about our solution. So what did we develop? First, we worked with the vendor to develop a custom flat file format that the vendor could produce. So it was easily producible in the vendor's system. We have that data coming into CRISP, and we developed a channel. And in that channel, the channel takes in that customized flat file, and then we convert it into the standard. So we take what the provider can produce, and we produce it into something that's easily readable and ingestible by our system. And then from there, now we have a standard clinical note, and that note can go through our regular processes to populate clinical notes in our CRISP HIE portal. So going on to the next slide, I'll show you what you would see as a provider or as a care manager. So within the CRISP portal, in our clinical information in the health records, there's an area where you can see clinical notes, and you'll see here the note is at the very top of this list of notes. The source would be my virtual MPC, and the provider would be the clinical provider for that patient. The next slide shows what the actual clinical note looks like. And it looks like a standard clinical note. It shows the patient's what occurred during that clinical encounter and any follow-up that the provider noted in the clinical note. So I'm going to turn this back over to Angela, who can talk again about what having this integration on their system meant for their care management team.
So Mary just showed the snapshot of what the note looked like, but I wanted to walk you through a real member case and show you what using these notes would look like in our practice. The details are all here on the slide. I'm not going to read through all of them, but the highlight is basically because the telehealth visit note was available in CRISP, the care manager received this referral and had a clear picture of this member before she picked up the phone. And that's really the key difference. In the past, anybody who's done this care management outreach for MCO specifically knows it's a lot of cold calls. Sometimes we have a name and a referral reason. In this case, it would have just been that a virtual visit occurred and not much else. Sometimes we wouldn't even know if the member necessarily needed a follow-up outreach. But with this integration, the care manager already understood the member's functional status, her barriers, and the most pressing needs before making that initial outreach. I'll share in more detail on the next slide what that looks like, but the takeaway is really pretty straightforward. By having this clinical context up front, that changed the quality, the efficiency, and really the speed of everything that followed during that care plan. Next slide, please, Kevin. So this is, hold on one second. Sorry. As I mentioned, this is the telehealth notes were already available in CRISP, and care management had an immediate insight into the member's functional status, her barriers, her unmet needs before we made that first outreach. So we were no longer starting from zero. When we received the notification of the visit, we already knew that she was bedbound, that she had a part-time caregiver at home, that she had medication sitting at the pharmacy that she had no way to pick up, that she had been discharged from her PCP and needed a provider, and that she had a ton of DME needs. The key insight isn't really the list of her problems, but that the care manager was able to know all of these things before we made our outreach. By having that up front, we can ensure this member was outreached by the best team to support the specific needs she had. And we could also begin working immediately on those needs instead of potentially uncovering these things over multiple phone calls. Because we had that upfront, we prioritized and coordinated next steps without missing critical information. We were able to make necessary referrals. We connected her with a new PCP and a care coordinator who helped her obtain all of her required DME, and none of that required a reassessment from what the telehealth provider had already documented. This really led to better coordinated care and a shortened time between interventions, reduced duplication of work as well. This person who was bedbound, disconnected from primary care, and really couldn't even get her own medicine was now managing her own health independently and reporting improvement. So care management was able to address all of her needs more quickly. And then when she was able to connect with the PCP, they could see what was already evaluated in the telehealth visit, what interventions were initiated, and how her symptoms had evolved over time. That visibility allowed the PCP to retain clinical oversight and make informed follow-up decisions. Because they could see the interim interventions, they could decide what needed to continue, what needed to change, and what further follow-up may be required. Next slide, please. So the payoff is really over the long run. The connectivity means that the encounter becomes part of this member's, your patient's longitudinal health record. So it's not just a one-time fix, but really foundation for ongoing continuity of care. Before CRISP helped us with this integration. The virtual visit was essentially a standalone event. The telehealth provider documented their findings, but that documentation stayed in their system. The PCP couldn't see it, the care manager never saw it, so it was as if it never happened. But now these notes flow into CRISP on a daily basis and become available to anyone on the care team, which means much less fragmentation, less duplicative work, more informed clinical decision making at every touch point. I think probably the most exciting part is that supports sustained improvement in our members' health, which we can provide better follow-up, more accurate monitoring, and ultimately support these members in improving their healthcare and leading to better outcomes. So we really do appreciate Chris taking on this challenge. It was, as Mary mentioned earlier, not as straightforward as we had hoped it might be, but they really worked very closely with the vendor and with me and our team to make sure that this actually came to fruition, and it has been a huge help since it went live.
Oh, thanks, Angela. We feel the same way. Going on to the next slide, I just have some final thoughts, and these are not as much of a wrap up, but just things as I was reflecting on this project with Angela that I was thinking about, and especially things that could be helpful to providers and other health plans in the community. Um, One is like as we work with health plans, especially the MCOs, especially their care management teams, we're building stronger connections with our providers as well. So the more that we can share data, the more we have a stronger foundation, just as Angela was talking about, for that, seeing the whole series of patient encounters turning into the landscape of that patient's health. Um, the other thought I had about this is if you have a provider, if you're a provider and want to provide more data to CRISP, um, come to us and talk about solutions. Like in this case, Angela talked about not starting from zero with data available. Well, we weren't starting from zero either when we had my virtual NPC provider come in who was not able to provide in a standard. We were able to work with that provider. We were able to leverage existing functionality and pathways, and we were able to flex those to meet the needs and the ability of the provider to submit data. This idea for integrating with this provider and facilitating better care management for Angela's team came from her team. Bring us ideas. We want to work with you. Stronger, more data means a stronger system for everyone. And then one of the other reflections I had in thinking about this work is there are a lot of our, especially larger providers and even one of our payers out there that have CRISP data integrated into their EHR. So instead of having to go to the CRISP portal, they actually have data integrated into their EHRs. But NPC does not have that ability because of their data systems. However, that didn't stop them from integrating CRISP data into their workflows. So Angela's team has care managers who have workflows, and part of the workflow is to go look for resources on the CRISP HIE portal. So even if you don't have that data get integrated right into your EHR, you can still integrate it into your workflows. I'm very proud of the work that we have done with Angela MPC and with all of the health plans in the state of Maryland over the last few years. We've built strong connections with the care management resources in the teams and a lot of the projects that have been initiated by the health plans and the care management teams have benefited all of our users across all of our different CRISP services. So. That wraps up our presentation for today. Angela, is there anything that you wanted to add to the end?
I don't think so. I really do appreciate, the work with us, and we're gonna keep bringing you great ideas. You haven't turned anything away yet, so.
Thank you. We are here for you.
Awesome. Thank you so much. We have some questions, but I will take a second just before we get to those to remind folks that we do have a survey about our entire summit. You can use that QR code on the screen now or use the link in the lobby to take that survey. It only should take a few minutes and helps us plan and prepare for next year's session so we can continue to make this as valuable for our audience as possible. All right,
Kevin, your
so
lineup today is really great. I've like so much enjoyed the presentation so far.
thanks, Mary. This question I think might tie to your closing thoughts, Mary. Someone's asking about what makes a vendor relationship valuable with Crisp and scalable across the network rather than just feeling like another vendor that we're working with.
And if I'm the term vendor, I think one of the things here was the vendor to Angela, who is my virtual NPC vendor, was also a care provider. They're a HIPAA covered provider. And so when they came in for the integration part of the work, we did not treat them as a vendor. We treated them as any other provider coming to us to submit data. And we had the added interest that we knew that Angela's team at MTC really wanted this data, and Angela's team was also going to be promoting that data was available on CRISP to their provider community as well. So this is a little bit of a different being this. We did not treat them as a vendor. We treated them very much as a provider.
Thanks, Mary. This question might be better for our outreach team, but someone's asking, how do we integrate case managers and social worker discharge planners at hospitals, maybe to CRISP? Um,
I,
I don't
I
know if you
and
have thoughts.
I would love to see more. I'd love to see the more data that we can get into Chris, the better that we can make this resource available to all the folks in the state that are providing care to our patients. Um, so I would say, yes, I'm going to turn that question over to the outreach team. But also, yes, I agree. Let's get many levels of resources engaged in working with CRISP. And I think it's that care management team that does an incredible job getting in there and understanding what patients need and how they can connect them with different resources in the community and with the healthcare system.